Hi, welcome to a session on history taking for paramedicine as part of the paramedic degree. Okay, we're going to look at the concept of sample as a system of taking a history, and we're going to look at some of the finer points of history taking. Obviously, the main thing to think about when we're taking a history is to try and make sure that we don't miss any parts out that might cause the patient ultimately to have some damage later on. One of the most important parts of history taking is where the history comes from, and obviously it can come from the patient themselves, it can come from family members, or it can come from bystanders. And the most common question, I guess, as a paramedic you'll ever ask is, okay, well, who saw what, or how did it happen? Those sort of questions are ones that we're going to be asking every day. Sample itself is really just a system. It's called an acronym, but it's a system of actually remembering which bits need to be done. Not always in that order, but we should make sure that every time that we're taking a history, we try and ensure that we cover all of the areas of sample. There's a lot of signs and symptoms that people can have. Okay, there's loads and loads and loads of words that will come up during our journey into history taking. And as we go through the next couple of years, we're really going to have to become very organized in the way that we do our history taking, because ultimately it's a key part of all of the OSCEs and it's a key part of your day-to-day work. Sample itself relies on us understanding the concepts of signs and symptoms, allergies, medications, previous medical history, last eating, last drinking, a few other areas on that one, and the events that actually led up to any incident. And that's normally how we would start to build a picture of a patient's history and an event. So as I said before, sample, signs and symptoms, allergies, medications, past medical conditions, and we've used the word pertinent to mean the ones that are relevant, last oral intake, and also we will look at output in that area, and the events that led up to any illness or injury. Okay, it's really important for us to be able to differentiate at this really early stage the difference between a sign and a symptom. And I know that most of you will be familiar with the concepts of both, but signs are things that you can see or hear, and symptoms are things that the patient can tell you about. So another little video, just a quick one. So as I say, signs, really, really important. And signs really for me are things that you can detect using your senses, okay? So things that you can see, you can smell, you can hear, and you can touch. And we know that the sense of taste is there, but don't use it. Please don't use it on patients. Symptoms. Symptoms are the things that people tell you about, okay? So signs, things that you detect with your senses, and symptoms, what the patient complains of. So symptoms are the things that the patient or their relatives tell you about. Okay, allergies. The relevance of allergies, there's quite a lot in pre-hospital care where allergies needs to be thought about. And it's not just because the patient may be having an allergic reaction when we see them, but also we have to remember that some of the things that we'll give the patient when they're in our care, they may be allergic to, and it may trigger an allergic reaction, which if the patient's already poorly may make them even worse. But also we need to think about the fact that they may have allergies to certain foods. And if they're going into hospital and could be in there for a couple of days, then again, it's really important that we gain that information and we hand that information over at a relevant stage. Patients can be allergic to all sorts of things, and we have patients now who have something called polyallergy syndrome, where they have lots of allergies or multiple allergies, up to 20 allergies in one specific patient. So again, we really need to get as much information as we can. There are things like the medical alert tags that are clues to us, or patients quite often have lists of their allergies if they are one of these that have multiples. Medication, obviously people take lots of different medications. So we can have the standard medications that are prescribed for them, or over-the-counter OTC medications. But also people will be taking things like vitamins or certain herbal remedies that can actually leave them feeling really quite poorly. The birth control pill, ladies can be on birth control pills, and that may have side effects which could be causing what you're seeing. And obviously people do tend to take illicit drugs, okay, and may not be that forthcoming, but it could be a reason why they're presenting the way that they do. So if possible, you always try and discuss medication, okay? Do it sensitively, but ultimately have the question around all types of drugs. Try and get a list of medications and then take those medications with you. And more commonly these days, we like to take the patient and their medication together. If you find a patient on home oxygen, remember to record the rate and the types of mask that the patient is taking so that they can continue that same level of care when they arrive at the hospital. And the sort of questions that you'll be using is really, what did you take? When did you take it? How much did you take? So just framing questions in a nice open way. Now, past medical history is quite a complicated one. We're obviously trying to find out what medical problems the patient has. So if there's anything there underlying that could be either causing it or maybe affected by the current condition. Have they recently been to hospital? Have they seen a doctor recently? Have they had any recent medical procedures, recent accidents or falls or trauma? If there are any clues, either medical alert tags or clues of medical equipment or drugs equipment within the house, then there's a lot of things that you can actually pick up just by entering patients' homes. Ask the questions around medical history. In my own practice, I use the mnemonic CRENSON as a way, again, of getting into that previous medical history. And it seems quite strange, but a lot of patients, when you use big words, don't necessarily understand or don't necessarily respond in the way that you would imagine. CRENSON, cardiac, respiratory, endocrine, neuro, surgical, obstetric, and natal. Now, I'm not going to ask a patient if they have a cardiac condition. I'm going to say, have you ever had any problems with your heart, such as a heart attack or angina? Have you ever had any problems with your breathing, such as? So I tend not to use the big words, but I will use words like heart, breathing. Endocrine, this is diabetes or Addison's crisis. So again, have you ever had or do you suffer with diabetes? Or have you ever heard the words Addison's crisis or Addison syndrome? Neuro, I tend to ask about stroke and epilepsy. Surgical, have you been into hospital recently? Have you had any recent surgery? Obstetric, is there any chance you may be pregnant? And natal, have you had any children? How many children have you had? When did you have your children? Is there, is this likely that there's any complications associated with previous natal history? Last oral intake and output. Now, quite often in sample, people just use the L part for last ate or last drank. But obviously it's really important, especially if the patient is vomiting, when did you last vomit? When did you last pee? When did you last poo? Because retaining pee and poo is as dangerous as getting rid of too much of it. So, we want to know if somebody's constipated or has retention, then, those could be causing the signs and symptoms that we're getting from the patient. So don't be frightened to ask the really awkward and bigger questions around oral intake and output. The last one are the events that led up to the call. Okay, what happened? What were you doing? Has anything unusual happened? And if the patient is conscious and able to tell you, and they're saying, okay, yes, I suffer with asthma, and yes, I regularly have asthmatic attacks, what is the difference this time? What's made you call us this time that wouldn't normally cause you to call us? The last bit really is about writing it up and asking the questions. So we try and ask all the questions in history, taking with as open-ended question as we can. Have you ever? Yeah, those sort of questions, okay? Don't be frightened of long pauses. 5 to 10 seconds when somebody is poorly is not unusual. So don't really worry. You could ask a question, do you suffer with? And there may be a pause before the answer comes back because the patient just isn't well. Try not to fill that pause, certainly for about 10 seconds. Remember to write down the negatives as well as the positives. So if somebody says, no, I haven't, that's just as relevant to us as yes, I have. Remember to write everything down or to tap it into the electronic patient record because the history taking, once you leave the patient and you hand them over, that piece of history may be gone forever, especially the sort of stuff that you're seeing when you went into the patient's house. Practice. History taking comes with practice, and the one thing that I'll ask you to do is to keep practicing. All right, perfect practice makes perfect. Okay, if you practice badly, there's a likelihood that you'll continue to practice badly. You have to try and get the practice as close to perfect as you can every time. Okay, that's it. That ends this session. Thank you.